Yes, I've just amalgamated a couple of presentations here, and it's about the history. It started off about the history of learning disability nursing, because learning disability nursing was 100 years old last year. I know the rest of the nurses are celebrating this year, but I thought I'd just let everyone know we got in there first. And the future for learning disability nurses, because there's some changes coming in Guernsey. We're following the UK, we're a little bit slower. So I'll just start off with our history, which is... So this is years ago, before the industrialisation, people with learning disabilities, who might have been considered by all these rather derogatory names, were supported in the communities by the families. But as the Industrial Revolution came about and industrialisation, people moved into the towns. So they are very, very derogatory names. And they would have worked on farms and such like. This is a picture that I found of Calderstones. Calderstone's a very large mental institution. I don't know how they managed to get all those people to stay in bed, because I'm sure you couldn't do it on a ward with non-disabled people. So I bet they tied them into their beds and wheeled them in there. But for me, when I started working with people with learning disabilities, Wixley was up the road. Now, Wixley was a home for inebriates. Around the turn of the century, lots of homes like this were built for people that couldn't be accommodated in society, seen as problem people. So there would be drunk people, there would be people with learning disabilities. There were also unmarried mothers in there. I worked with a man who was in his 60s by the time I worked with him, who had grown up in Wixley because his mother was unmarried when she became pregnant. So in a sense, he didn't have a learning disability, it was just learned behaviours that were very bizarre. So they used to call them the nibs locally, apparently, and they used to work on the farms. And Wixley, for a small institution, is quite large. It's now a fancy housing estate now, but they closed it in the 90s, and the people moved into what were hostels and then out into the community. But learning disability nursing came from, obviously, these big institutions, and when they had these big institutions, they had psychiatrists and they needed nurses to look after the people, and that's how we came into being, looking after people in those institutions, as those institutions were developed slightly before hospital, I suppose. So learning disability nursing today is about, it's the most holistic form of nursing, because we look after people from the cradle to the grave. We help people through all aspects of their life. So we want to assist those people into having a fulfilling and included life into the community. We want to enable reasonable access to social care and the other benefits that we all experience. And they just need a little more help very often. And a lot of the issues that learning disability nurses are dealing with is about capacity. Has this person got capacity to understand their tenancy agreement, to understand their healthcare needs, to understand the care plan that you've put in place? And that's why I wanted to come and talk to all the other nurses as a learning disability nurse, to say, we can help you with some of those people. I've looked into the statistics in our service, and we've got 270 people on our register. Statistically, in the UK, we should have between 1% and 3% of people with a learning disability. So they're out there, they're in the community in Guernsey, and probably because Guernsey is quite a protective, inclusive community, that they aren't in touch with services. But those people will still be vulnerable adults, still needing reasonable adjustments, and you probably encounter them when you're trying to explain a care plan or a discharge plan to someone that hasn't really understood. So there might be a role for the learning disability nurses in helping with reasonable adjustments to assist those people, and I think we've got to explore that within the service. Recently, the Foundation for Nursing Studies did a little bit of research, because learning disability nursing is a dying breed. There are less and less learning disability nurses getting trained each year, and this is a very vulnerable group of adults that we're supporting. And there's a lot of changes afoot in nursing practitioner training across the board, because now all student nurses have to have a placement in a learning disability area. So although we're not getting as many specialist learning disability nurses trained, everyone needs to work with these people. So that was just a bit on the FONS publication, because we often feel that learning disability nursing is stigmatised or less valued or less visible than other nurses, but we are there for people. We're supporting people throughout their lives, and we're supporting their families to try and be as included in society as possible. And we want to work as partners in care with yourselves, with all the other teams that are out there, making those reasonable adjustments for people with learning disabilities. So I was thinking about the best part of being a learning disability nurse is I get lots of time to learn about the people that I work with. They're not in the ward for a quick intervention or just to look at an issue. I get to spend, depending on how long I'm employed with them, a lifelong time with them, because I get to know them when they're well as when they're not well, so that I can advocate for them and help them and support them into the care that they need. And we act as a bridge between that person with the learning disability and other healthcare professionals. Estate agents, tenancy people, the prison, the probation service, we work with them all, which makes my job really, really interesting, because I get to see all sorts of things. When the person that I've got with a learning disability is a medication issue, I'm going to come and talk to the pharmacist. But when they've got a continence issue, I'll talk to the continence nurse, which means that I get to speak to lots of people, and it's really interesting. A lot of what we do is around the Mental Capacity Act. Has this person got capacity? And we need to take that time to be able to make sure that people have understood the information that they're being given. And that's something that learning disability nurses are supposed to be really good at. We need to take that time, make the reasonable adjustments, find out the best communication method to help that person. And that's where we can assist people in the wards if they're not understanding their care plans or the implications of their illness. Then maybe we can spend more time with them and help with that. Making the reasonable adjustments that are required now by legislation. And we can work with you, we can work with everyone else. We want to work with everyone and help the people that we support and help the other practitioners to understand the needs of the people that we're working with. So we want to be one family with all the other nurses. And there's a lot of evidence to say that people with learning disabilities have less favourable healthcare outcomes than the rest of society, the rest of the community. The MenCap reports of death by indifference and 74 and counting all suggest that people get less favourable healthcare when they're in hospitals, and there are multiple reasons for this, but we can actually help with that. We can probably spend more time with that person than the sisters or the nurses on the ward, because we understand those pressures, and maybe we can help with that. The mortality review, the Learning Disability Mortality Review, suggests that I think it's men die 13 years younger than the average in the population, and women die 23 years younger than the average in the population. Might got that the wrong way around. But there is an inequality there, and that's why the legislation, that's why the NMC and the RCN are promoting everyone to get involved in working with people with learning disabilities and understanding the challenges and the comorbidities that they often face, because they often have multiple health conditions as well as lack of understanding of how to look after themselves. So reasonable adjustments are a legal duty now, and there are all these standards with the training to advocate that we must get better at this. So within Guernsey, we've got the 2020 Vision, the Partnership of Purpose and the Inclusion Strategy, the Disability and Inclusion Strategy. And these are all further guide us to the fact that we actually need to develop services for the vulnerable people in line with everyone else. So we're going to have a Mental Capacity Act. At the moment we've been kind of using the UK one, and the discrimination law is to be implemented, and safeguarding. So when people are getting less favourable care and support, then that could arguably be discrimination, it could be safeguarding, and we need to make sure that people have got capacity to understand, and so that we can deliver the care effectively. So there's a new role coming to Guernsey. It's going to be a learning disability liaison nurse. She's going to work and be based in the hospital. The role of learning disability liaison nurses, because we're getting into the future now rather than the past, is to work alongside the other healthcare professionals, looking at the reasonable adjustments that could be made in hospital. I was talking to a family recently that their son is very difficult to get to a medical appointment, and I said, well, how about we talk about it, we plan what time that appointment's going to be, I'll link with the doctor, the consultant, and we'll practice getting him, and it might take 3 months to get up at that time and be in the hospital at that specific time. And we could do that by lots of practice, and then we could have got that person to that appointment. So by talking and thinking about these things, we can make the things happen. That consultant does need to see that person, and the parents were just mystified about how it's going to happen. We can talk about it, we can find ways to make it happen. And there's got to be strategic development within the hospital to embrace these changes and this education that needs to happen around people with learning disabilities. But the learning disability nurse isn't there to do everything. They are there. This was a quote from the head of nursing at Oxley's when I emailed him about something, and he just said, learning disability nurses aren't solely responsible for the adjustments, they're there to make sure everyone else does. We need to guide people into thinking, how could we do this? Could we do this with a double appointment? Could we practice taking this person in at 2 o'clock so they get used to travelling to the hospital at 2 o'clock so they can make that appointment with, time-pressured doctors and consultants on time. So that's a quick run through of where we've come from and the future that we hope is going to be really good, and we're going to engage in lots of training for adult nurses in the learning disability service. So we all need to all come and join us, and also talk to us if you've got someone that doesn't seem to understand. Maybe they need a referral, maybe they need some sort of reasonable adjustments, and maybe we can help with that, and look into, can we provide a picture journey to help them in their hospital journey, or something easy to read. So that's it from me. Has anyone got any questions?
What is Medicines Reconciliation? So essentially it's a formal process that can be undertaken by a pharmacist, can be undertaken by nurses, which is what we kind of want to embrace a little bit more, and prescribers. And again, we want to engage a bit more with our prescriber partners to make sure that there is a complete, accurate medication information at transfers of care. So it's at the interfaces, so it's when patients are admitted from primary care into secondary care, which is something that we are doing a little bit of work on at the moment, but it's also at the discharge end of things, when patients go from the hospital back to their GPs. So this is how it happens in a nice pictorial view. So when a patient is admitted to hospital, we obtain a medication history from either them or from a GP history, from the medicines that they might bring in, or from the nursing home that they've come from. Then we need to verify that history, because obviously when patients are admitted to hospital, they're ill, and they might be under an element of distress, they might be in pain, and then they might not recall everything. They may, have an element of dementia or learning disability, as we've learnt, and so, to sort of put them under the firing line and say, what medicines are you on, might not be something that they can recall. So generally we use a couple of different sources to verify the history. So we speak to the patient's GP. Again, we look at, perhaps we'll get the patients or the relatives to bring in their medicines so that we can see what they're on, or speak to some relatives or carers or the nursing home or whatever. Obviously, once we've done that, that's our starting block. The patient is in hospital for a reason, so more often than not, they will have some changes in their medication during that treatment period, and it's about communicating those changes again back to the GPs and making sure that the GPs then make those changes in a timely manner, and the patients get the medication that the consultant intended them to have. So, it sounds pretty obvious, doesn't it? It sort of, kind of, hopefully makes sense, and we probably think that it should already happen, and that's something that might come as a surprise to people, that it doesn't, and it doesn't happen in a lot of instances, and it doesn't always happen in a timely manner, and it can result in poor care and poor outcomes. So the doctor's written up everything on the drug card, so what's wrong? Why is that why would you think that would be a problem? Yeah. I didn't try. So if the patient's told the doctor what they're on, or the patient's brought in their own medicines, so don't necessarily mention the fact that they took some herbal remedies as well, or that they bought a cream the other day, or they've got some ibuprofen for their knee ache or something like that. So we need to check those preparations out. Quite often patients don't associate creams and ointments as eye drops as medicines, because they think medicines are something you swallow. So they might not mention those.
Even inhalers, they don't think it's medicine.
Yeah, absolutely. Yep, inhalers. Multiple prescribers. So at the moment, we don't have a very joined up system in Guernsey, despite us being a small population. We have GP notes, we have MSG notes, we have mental health notes, we have oncologist notes, we have off-island notes, and most of the time they aren't in one place at one time, or in the place that you need them at one time. And the mental health notes and the mental health prescriptions may or may not be available to the prescribers, to the GPs, or they may not be up to date. And the oncology prescriptions, more often than not, I don't think the GPs have any idea. They might know that the patient's being treated for cancer, but they might not know what that involves. Obviously, patients themselves may be poor historians. A GP may do a home visit, handwrite out a prescription for an antibiotic, or furosemide if the patient's in heart failure or something like that, and then he's gone on to the next home visit and blah blah blah, but he doesn't update his electronic prescribing record to reflect that. After all that, the patient obviously might not be able to recall what they're on. So it is obvious that it should improve patient safety, because it is important that that we all know what the starting point is for our prescribing and our treatment plans while the patient is in hospital. It's part of the Care Value Frameworks Principle 2, which is to provide harm-free care to our patients. And it also picks up dispensing errors that might have occurred in retail pharmacy. We're all, as pharmacy employees, know that we're all capable of making mistakes. We're all capable of making dispensing errors. Retail pharmacies are very high pressured. We interviewed a technician the other day who works in a pharmacy where they dispense 25,000 items a month. Yeah. Which most retail pharmacies, I know they had a record at St Martin's Pharmacy, which was 6,000 items a month. That's a record for that pharmacy, which has been in practice for a long time. So if you take that down to its nth degree, it effectively means they're putting something out every minute, and that doesn't account for the fact that some patients have come in and asked them to give advice, and they've had to sort out some queries on prescriptions, so it probably cuts down to that. So they can make errors, and those errors can result in patients being admitted to a hospital, and we can pick those up and identify those and feed those back. Delays in information from hospital to GPs. And also nursing home residents often have delays in starting the new medications due to dose sets being prepared weeks in advance. You used to work in retail pharmacy. You want to tell us some of the issues that you had?
When patient would be discharged, the nursing home wouldn't have update, we wouldn't have update in the community pharmacy, we would use the old prescriptions still from the GP. GP doesn't have the notes yet, discharge notes, the medication will change. So that's one of our issues.
So there's delays in getting that. So there's delays in getting that patient. The patient's medication might have been changed. They might have been stabilised while they're in hospital, but quite often there can be another 2 or 3 week delay before that is actually communicated to real-time treatment when they get out. Adverse drug events are a leading cause of injury and death within healthcare systems around the world. And that's led to the WHO Patient Safety Challenge medication without harm, and the challenge was to reduce medication errors throughout the world by 50%. So it's a big challenge, but WHO don't deal with small challenges. WHO look at way back in the day, polio, and the incidence of polio and the incidence of death from polio, and that sort of introducing vaccinations. And as we've gone down and cured predominantly cured a lot of those infectious diseases by meeting these WHO challenges, things like medication safety have risen to the top of the pile as reasons for patient being admitted, reasons for patients dying and being injured. One of the reasons that these happen are poor communication between health professionals and again at that interface between primary and secondary care. So around half of medication errors in hospital occur on admission or discharged, and about 30% of those errors have the potential to cause harm. So it is an issue. And 67% of prescriptions on admission have one or more errors on them. So why else should we be doing it? It is cost effective. It does save HSE money, which is what our finance people want to hear. This is East Lancashire did some research on this, and out of 864 medicines reconciliations, 13% of newly admitted patients had a preventable adverse drug event, and the net benefit of one patient's medicines reconciliation was between about £34 and £80 savings to the hospital, because adverse drug events tend to prolong patient stay or cause more injury that needs addressing and is costly. So this is the third global patient safety challenge that I mentioned before. Medication without harm aims to reduce severe avoidable medication related harm by 50% globally over 5 years, and that was launched in March 2017, so nearly 3 years ago. So I'm sure we'll be getting some feedback on how that's going. It's a pretty ambitious target, and we need to be part of that. As a consequence of that, there's quite a few reports fell out of that challenge, and one of them was the WHO High Fives project, which actually gives a SOP for doing medicines reconciliation and ensuring that we get accuracy at the transition of care, because this is global. It's not just about the UK. This is about Africa. This is about New Zealand, Australia, America. It's worldwide, and there's a lot of work being done throughout the world to try to address these issues. So if you go to Africa, you're going to get a medicines reconciliation when you go to hospital. If you go to America, you're going to get a medicines reconciliation at a hospital. So we should be doing it as well. So NICE and the UK Department of Health set up a short life working group after the WHO challenge was issued to look at how we could reduce medication-related harm in the UK, and as a consequence of that they produced the NICE guidance, which says in an acute setting accurately list all of the person's medicines, include prescribed over-the-counter complementary medicines, and carry out a medicines reconciliation within 24 hours or sooner if clinically necessary. So we also have our own regulators that support this, underpin this. So if we're not doing it, then we are coming up against our own professional standards, and we can be challenged by our own professional bodies for not doing this. So the GPHC states that at pre-admission, on admission or at first contact, patients' medications should be reviewed to ensure an accurate medication history for clinical appropriateness and to identify patients in need of further pharmacy support, which is why you have your pharmacists going around the wards every day. Patients' medicine should be reconciled before planned admissions, and within 24 hours of hospital admission for unplanned admission, and they should be effectively documented and to identify any medicines related issues on admission. General Medical Council says that any changes to the patient's medicines should be critically reviewed and quickly incorporated into their record, and doctors should confirm that their patients are taking the medication as directed. It's all right to write a prescription. That doesn't necessarily translate into the patients swallowing the tablets for a whole variety of reasons. That's another talk altogether. And they should always be checking that the patients are still needed, that the medications that they've prescribed are still needed, so they should be reviewing those regularly. On our own incident reporting system, and these are old, there's been many more incidences, and if we'd had a bigger group, I had a bit of a practical exercise that we could have done, but we can still do it with the pharmacy lot if they want, because they haven't seen it, but if people want to do it, just to look at some of the issues that we just identified in the last couple of weeks. We just found some practice ones. A patient had quetiapine. It was documented on the anaesthetic notes as pre-admission that this is what this patient was taking pre-admission, but that didn't get transcribed to the drug card, so the patient missed that for several days. The same patient, unfortunately, and I know this one particularly well because they issued a complaint which was fair and correct. The anaesthetist had done the medication history a couple of weeks before the surgery. It was due. The patient had then been cancelled, so they came back a couple of months later. They used the same medication history, and in between times the patient had been to the GP and had a few things changed. I know that the anaesthetists have now changed their practice, so they don't actually generally write up the drug cards until the day of admission as a result of that incident. So this is where identifying these issues can help improve patient safety in the long term. We've had many incidences of patients being sent home with other patients' medications. Patients come in to hospital, they get their medicines put in a green bag. For whatever reason, maybe the bag wasn't sealed properly and it's opened in the cupboard and the nurses have just shoved the bags in there without checking. And of course that's a GDPR issue as much as it is a patient safety issue. I've had patients who were prescribed phenytoin for epilepsy on a medical ward, but that got missed off the prescription and didn't get picked up until the patient had been in hospital for several days. And of course there's risk of the patient fitting if they don't have that medicine. So why else should we be doing it? Effectively, because everyone else is, which is not always a good reason to do things, which is why I put it at the end, but in this case we need to again keep up with that WHO challenge and the support that WHO are giving organisations to do that. So at the moment these are places in the world where it's happening, but again this list hopefully will have grown since I've done these slides. So how can we do it? I have got a copy of the drug card if people wanted to have a look at it. Pharmacy lot will know, but we've designed a new drug card, and I know it's had its issues, but one of the positives for that is that we have done a section which is inside the drug chart, first page of the drug chart, which might be on this slide as well, which identifies, which gives us an area where we can do this medicines reconciliation, because part of the issue is that we need to document this as well, because there's no point doing it if you've just had a conversation with the doctor and then the doctor didn't write up or didn't do what you said, or he went off and did something else, because that information is then lost and we still haven't improved patient safety. So we'll have a look at that in a wee minute. The other area that we're looking at is pharmacist and doctor co-prescribing in the emergency department. Again, our friends in East Lancashire Hospital and there's also an Australian study where they placed a pharmacist in the emergency department, and the patients were admitted, and the pharmacist's role was to take that medication history, sit down with the doctor who was busy doing the blood tests and ordering the CTs and whatever and whatnot, and physically examining the patient, and then once sort of collate all that information so that when the prescription was written there on the point of admission, it was as accurate as it could be and appropriate for the patient. So sometimes it is appropriate that medicines are left off if patients got a degree of renal failure. We don't want to be giving them non-steroidals and ACE inhibitors and that kind of thing. So that can be so the pharmacist can document those reasons why. And Terry's had a session last year, or was it the year before? Down in ED, trialling that out, and we have now got a paper that's going to go to CNT, where we're sort of trying to combine this role with the polypharmacy role, so looking at reducing the number of medicines that patients need. Or making sure that the patients get just what they need, and things that they may have been started for a short term and have inadvertently been carried on for 6 months, 6 years or whatever, are actually reviewed or are appropriate what they are in the long term. Pharmacy technicians on wards. Again, Beth will know we've been trying really hard to get that role sorted out. We've been a bit plagued by having a shortage of technicians and the ability to recruit those on island. So that's been a wee bit dogged, but having said that, we also did get approval for a prioritisation for 2 discharge technicians, so we just need to follow that up with the business case. And again, I just ask for your support when these things go to CNT, that it gets the support that it needs, knowing the importance of medicines reconciliation. And again, pharmacists speaking again at discharge and perhaps writing the prescriptions so that we know that that information gets communicated to the retail pharmacies at the point of discharge, and to the GPs at the point of generating that next prescription. So this is the drug chart they've just handed out. So again, it's a pharmacy medication history. So as a general rule, pharmacists will confirm a medication history. They don't have to do everything. Nurses can identify if a patient says, oh, I normally take that, why is that not on my prescription? A nurse can write that in there, and then a pharmacist or the doctor can come along and finish off this section here, and it's up to the prescriber or the pharmacist to sign and date that in the end column to say that that's the course that needs to be taken. So if it is a drug, so if a nurse identifies a drug that's missing, they just fill it in here, and then the doctor or the pharmacist should come along, decide, or discuss or ascertain whether it is actually to be stopped, which is fine. If it's to be stopped, then either the pharmacist or doctor sign and date that. If it's to be held because maybe they've got poor renal function, then again that should be verified with the doctor and the prescriber, or if it's to be reviewed. And generally, some of the doctors are very good at filling that in, and they'll write a review, after 5 days or 3 days if a patient had poor renal function on admission, or the patient had diarrhoea, so they've withheld the laxatives or whatever. And sometimes they decrease doses if the patient's hypertensive or something like that, and they may decrease the doses. So we only list the discrepancies here, but again, it's important to address those discrepancies, not just to solely list them, because we haven't sort of solved any issues by just writing that down. Okay, so this is the East Lancashire Teaching Hospitals paper of their pharmacists in their emergency department. 2,085 patients went through in the time period that they did this study. There were 623 interventions. They stopped 179 medicines, and they prevented 129 on-call queries. So that's quite a lot of interventions, which would introduce medicines reconciliation. So we've listed those. We spoke about those earlier. And again, at discharge, at the moment, a lot of this work is sort of falling a little bit between the holes. The nurses do what they can do on the wards, and the other advantage of pharmacists or technicians doing this is, of course, you release the nursing time to do other things, which are nursing related tasks. Summary care records. This is something we don't have, and I don't know if this is something that's being considered in the Partnership of Purpose or the Transformation Fund, but I think it's something that we should be looking at as an organisation, because a summary care record is basically a summary of the patient's care and their medication history. That's generally kept centrally, so it's something that the GPs have access to and can contribute to and can update, and at the hospital, again, consultants can contribute to and update, and obviously there are varying permissions, but it's something that you might be able to access as nursing staff when a patient gets admitted, or we might be able to access again as pharmacy staff, just as a read-only summary, and obviously, varying permissions depending on who can contribute to it and who can just read only and see it. But it makes a big difference in the UK and how this information is transmitted and how this interface is made better. What's kept in the summary care record, those sort of details, and that's it. Yeah. Okay. So there's a lot of information, there's a lot of data out there, there's a lot of papers out there. So if you knock your socks off if you want to learn any more. So thank you very much.